as stated, this is the New York City Department of Health and Mental Hygiene's update on COVID-19 for New York City healthcare providers. We thank you for joining us today. Please note that, as always, you have been placed in listen-only mode, so that means if you have questions during the presentation, we welcome you to submit them via the Q&A portion of the WebEx, and we will address them at the end as time allows. The slides from this webinar, as well as a recording of the event, will be made available on the provider page of our website by tomorrow afternoon. And additionally, we thank you for your participation in a brief final poll that will be issued during the last 5 minutes of today's webinar. So today we're joined by Dr. Madhuri Didi Ray, Critical Care Planning Lead for the agency's outbreak response, who will provide COVID-19 updates for New York City. And we're very pleased to welcome Dr. Laura Riley, Chair of Obstetrics and Gynecology at Weill Cornell School of Medicine, for a presentation about COVID-19 and vaccination during pregnancy. So with that, I will pass it off to Dr. Ray to begin with those general COVID-19 updates.
Thanks, Allison. Hello to everyone, and again, special welcome to Dr. Riley. And Allison, could you advance the slide, please? So today we'll, as usual, go over general updates and a couple pertinent vaccine updates that have emerged recently. And then Dr. Riley will be talking to us about COVID-19 and vaccination during pregnancy. As always, the presentation and the recording of this webinar will be available shortly after the webinar is over. Additionally, we will be answering questions in the chat as we are able, and we will, if time permits, have a question and answer session at the end. Can you advance the slide, please? All right, and this is just our usual overview of the course of the pandemic in New York City. As you can see, we are in what we're calling a third wave of the pandemic, which began in the summer of this year. While there was a very high level of new cases in September, during October, the cases have begun to decline. We usually see hospitalizations and deaths follow the case patterns. But, since we have had widespread vaccination, the hospitalization rates and the hospitalization bumps and death bumps are quite low. The hospitalizations do continue to decrease. And can you advance the slide, please? So as usual, when we talk about the citywide pattern, citywide increases, citywide decreases, we do remember that because of structural inequities in our longstanding structural inequities in New York City, we see different patterns across the city. So while there may be an overall decrease in transmission and overall transmission is low, we do see areas of the city indicated by dark red in which transmission continues to be high. Can you advance the slide, please? And just to speak to that point, the data are presented here in a different way. When we think about the opposite side of the coin from cases, we have vaccination. These data are presented based on race and ethnicity. And you can see that while overall only 15.6% of New Yorkers have not received at least one dose of a vaccine, these numbers differ by race and ethnicity. You can see that while Asian, Native Hawaiian, and other Pacific Islanders have a very high rate of vaccination, for example, Black New Yorkers overall have a relatively low rate of receiving at least one dose of a vaccine. With adults fully vaccinated, you do see similar patterns, with 77% overall, almost 8% overall fully vaccinated, about 8% partially vaccinated, and again 15.6% not yet vaccinated. And can you advance the slide, please? I talked about cases and vaccination, and this is a graph since summer of cases by unvaccinated versus vaccinated. This and other data are available on our data page. There's a link in the slides. But what you can see is that transmission is largely happening. The new cases are largely happening among unvaccinated persons. So while there are some cases among vaccinated persons, unvaccinated persons are significantly more prevalent or incident. Can you advance the slide, please? Now, for some vaccine news you may have heard recently, CDC, since our last webinar, has recommended a single Pfizer booster dose 6 months after the primary series, which is 2 doses, for certain populations. So the recommendation for persons who should receive a booster are persons 65 and older, residents of long-term care facilities who are 18 and over, and people over the age of 50 who have a medical condition that increases their risk for severe COVID illness. Persons may receive a booster based on their individual benefits and risks, but the recommendation, perhaps could be discussed with individual family members, with a provider. If they are 18 to 49, so under 50 but still adults, and they have a medical condition that increases their risk for severe COVID illness. Additionally, persons 18 to 64 who are at increased risk for exposure and transmission because of their work or residence in an occupational or institutional setting. Can you advance the slide, please? So, the benefits of vaccination, whether they are the regular series or the series plus a booster, for people with a history of COVID-19 is, the benefits are large. There have been questions around New York City about whether persons who have had COVID-19 in the past and may have developed what we call natural immunity do need a booster or do need the vaccine. And the answer is it is definitely beneficial. Among people who have a history of vaccine, there is a smaller risk of reinfection if those persons do get the vaccine. Observational studies support this and indicate that unvaccinated persons were more than twice as likely as fully vaccinated people to get reinfected. The vaccination can boost the immune response for potentially a more durable, longer-lasting protection than natural immunity alone, and may additionally offer better protection against existing and emerging COVID-19 variants. People who have recovered from COVID-19 may be vaccinated as soon as they meet criteria to discontinue isolation. So as soon as they are not going to potentially infect others at the vaccine site, they are eligible to begin their vaccine series. Can you advance the slide, please? Similarly, serologic testing is not recommended for vaccination decisions. The existing antibody tests vary widely, but none of them can assess whether a person is protected against COVID-19. Aside from questions about the precision and accuracy of the tests themselves, antibody levels themselves may not correlate with immunity or even clinical protection. Studies refer to neutralization tests as surrogates of protection, but those neutralization tests are not available for commercial use, so cannot be ordered for a patient. Additionally, if a person misinterprets their positive antibody test, even if they are not directed by a provider to make vaccination decisions based on that, individuals may misinterpret the antibody test if they return increase their risk outside of vaccination decisions of being infected with and transmitting COVID-19. And can you advance the slide, please? So there are some, we spoke about the updated recommendations which occurred recently. There are also anticipated developments in COVID-19 vaccines which should not be put into practice yet, but you should be aware of the evolving news and recommendations. So the FDA Vaccine Advisory Group met yesterday and voted to recommend that the FDA authorize booster doses, so similar to what we talked about with Pfizer, of the Moderna vaccine. These would be half of the dose used for the primary vaccine series and half of the dose used for the primary vaccine series, and again will be evaluated by the FDA for safety, and eventually the recommendations will be decided by CDC. Today, there is a discussion and vote on whether to recommend mix and matching of different vaccines. So, for example, if you got Moderna for your first set, perhaps Pfizer for the second. ACIP will update or recommendations based on these data and authorizations on October 21st. Additionally, Pfizer has submitted data to support vaccination in 5 to 11-year-olds. The advisory committee meeting for the FDA is scheduled for October 26th, and the ACP should make a decision around November 2nd or 3rd. Moderna has applied for full FDA approval rather than emergency use authorization for persons greater than or equal to 18 years, and we will look forward to hearing more about that as we approach the end of the year. And advance the slide, please. Additionally, the health department is providing new monoclonal antibody therapy resources. There are links available in the slides, but we have specific links for providers and for the public who may receive the therapy. To find a treatment site or to schedule an appointment for an individual likely to be eligible who could benefit from monoclonal antibody therapy, you can visit heightsite.org/monoclonal antibody or call New York City Health and Hospitals at 212-COVID-19. And can you advance the slide, please? Now I would like to pass the webinar on to Dr. Riley, who will talk about COVID-19 vaccines.
Great, thank you very much. So I will try and talk a little bit about pregnancy. I suspect that most people know a lot of this data. I've tried to be very careful so that you can read the references and just recognize also that the data seems to come out pretty quickly now. It took us a little while to gather the data, but I think we know a lot more than we did at the beginning of this pandemic in terms of risk to pregnant women and the need for vaccination. So next slide, please. So these are my disclosures. I think the only thing I would say at the end here, you can see that I'm on the CDC work group for COVID vaccines, and I have been since the beginning. I'm also on the vaccine safety group for the COVID vaccines, and also very involved in ACOG's COVID vaccine activities. Next slide, please. So these are the recommendations that are all lined up, and I will point out where there's some differences. ACOG, the Society of Maternal Fetal Medicine, otherwise known as SMFM, and the CDC all have the same recommendation, which is that eligible persons greater than age 12 years, including pregnant and lactating individuals, receive the COVID-19 vaccine or vaccine series. The additions that we really want to stress for obstetrician gynecologists and family practitioners and midwives who take care of obstetrical persons is that we want that documentation of the discussion about the vaccine to be put into the chart. I think one of the benefits there is that with certainly with pregnancy, you have the opportunity to see people multiple times in the course of a pregnancy. And so you have the opportunity to ask questions and make it an ongoing discussion. Women's healthcare providers also should obviously lead by example and be vaccinated themselves, as well as encourage their patients. And then one other sort of pregnancy-specific thing is that the COVID vaccines can be administered simultaneously with other vaccines, such as flu and Tdap, which are the two vaccines that we strongly recommend for pregnant women in the course of pregnancy. So we want to take away whatever barriers there could be in terms of getting these vaccinations completed. And so needing another vaccine should not be one of the stumbling blocks. And because this comes up every now and then, ROGAM is not a reason to not give the vaccine either. Next slide, please. So Dr. Ray was just talking about the booster situation. And so I just want to point out here that ACOG and SMFM is a little bit different than what the CDC recommends here. And so I want to point that out. Essentially, the concern here is that ACOG recommends that pregnant people, including pregnant healthcare workers, receive a booster dose of the Pfizer vaccine at least 6 months following the completion of their initial series. And I will tell you the reason that we came up with recommends as opposed to may, which is what is in the CDC guidance, is because we felt that there is so much data, some of which I'm going to present today, that suggests that pregnant women are at increased risk for severe COVID-19 infection. We felt that we wanted women to be as protected as possible, and that would, in many instances, involve a booster. And so that's just, something that is a little teeny bit different than the CDC. The other reason that we came to that conclusion is because we felt that, physicians gave us a lot of feedback that initially our recommendations were not strong enough. And so you get into the office with a patient and you're trying to do the pros and the cons, and here you're saying it could be really severe, yet you're saying, oh, maybe you don't need a booster. So we thought it was just much clearer for obstetrician gynecologists just to recommend it for their patients. Obviously Pfizer. As we see the Moderna information and J&J information come out, I suspect that our booster recommendations will be the same. Next slide, please. So why do we even have these recommendations? Well, I think this is way back. It seems like in the beginning of all of this, but this was one of the earliest papers from England, which sort of described the characteristics of pregnant women who are being hospitalized with confirmed SARS-CoV-2 infection. And this was a small series, but essentially we have seen the same thing in the US. And again, here the symptoms, most women were complaining of fever and cough and breathlessness. The reason I point this out is because some of those things, the breathlessness, the tired fatigue, the headache, can easily be overlapped with just normal pregnancy stuff. So certainly in the beginning, we were having trouble figuring out what's just normal pregnancy and what could be COVID infection. The other thing you'll see on the right-hand side of this slide is that this was one of the earliest studies in pregnancy anyway, which started to help us understand that there were certain comorbidities such as obesity that would increase the likelihood that people were more likely to get COVID infection. Next, or to get sick with COVID infection and be hospitalized. Next slide. So with time, more data came out. This was one of the first systematic reviews of about over 500 pregnancies of women with confirmed SARS-CoV-2, and most of them had delivered by the time the paper was published. ICU admission was about 3% at that time, which is high for pregnancy. And then there was and what they considered critical disease, i.e., there were more women needing ICU admission, but ventilation and ECMO. In this particular data set, there were no maternal deaths, but things to sort of, I would say, when this paper first came out, these were things that we were all like, oh, is this real or is this not? The C-section rate was really quite high. Preterm birth rate was higher than it is than what you'd expect. And interestingly, the vertical transmission rate, which would have been, or the vertical transmission at all, which would have been the risk of an infected woman then infecting her baby, was actually very, very small. And so this was one of the earliest sort of looks, and I think that almost everything that was seen here, we then started to see on a larger scale. Next slide. So this is a paper, this is from Sarah Ellington's work from the CDC. And so this is when we really started to realize that pregnancy in and of itself was a problem. So this was one of the first, excuse me, one of the first papers that was able to look at women, SARS-CoV-2 positive women of reproductive age, look at pregnancy versus non-pregnancy. And having comorbid illnesses like cardiovascular disease, diabetes, and chronic lung disease definitely was associated more frequently in pregnant women who were sick. But I think what we really gained from this paper, which had been a question all along, is pregnancy its own risk factor? That's when we realized that it was, right? So we saw an increased risk of hospitalization, of ICU admission, mechanical ventilation, even though in this particular paper there were no differences in death. But clearly severe infection was something that we needed to be aware of. And that, I think, is something that is driving all of the recommendations that we're making at the moment. Next slide. Additional observations that came from some of the earlier studies that were smaller, databases, but important information nonetheless. This was a study, this top one, Corey et al., was 5 New York City hospitals looking at over 200 COVID positive pregnant women. And again, COVID severity in this particular data set seemed to be associated with a higher BMI, and also C-section rates were really quite high. I can tell you that when we started to dig a little bit further into the cesarean delivery rate, it's more driven by moms getting sick and people panicking that moms are sick or trying to sort of get them out of that state quickly, and then thus cesarean deliveries, and the concern about doing vaginal deliveries in this very sick population. Other observations that were made, this next one was from up at Columbia, where they found that COVID transmission amongst pregnant women was definitely associated with neighborhood markers of household crowding, as well as low socioeconomic status. And then this last paper was from Boston, actually, from MGH, looking at a much higher rate of COVID infection, in Hispanic women. And so all of this data, I think, although early and came in fits and starts, I think paints the picture again that the disease is really quite serious in pregnancy, and the same populations that were particularly sick with COVID in the non-pregnant population were the same as pregnant women. Next slide, thank you. So this is yet another paper. I think this one is the one that you will see most often cited because it really has the most data. Here it's over 13,000 pregnant women, and this data has been looked at over and over again, and comparing it to over 83,000 non-pregnant individuals. And again, the risk factors for COVID in this data set, advanced maternal age, higher BMI, chronic hypertension, and diabetes. Having comorbidities were more likely associated with ICU admission and invasive ventilation. So those tended to be the women who landed in the ICU, although I think you'll notice as more and more data comes out that just pregnancy itself, even if you're young and healthy, but pregnant, given the pregnant physiology, that is associated with worse disease. And the outcomes you can see here. Again, the fetal and neonatal outcomes have been interesting. Different data sets give different information. Preterm birth rates seem to be elevated. Stillbirth has been seen higher in some data sets and not in others. Europe has seen higher, has reported higher stillbirth rates. US, not so much. Cesarean delivery, I mentioned already, and then NICU admission really does mirror preterm birth. Next slide. Next slide, please. Thank you. Additional observations. So this is much later data, and this comes from the Maternal Fetal Medicine Network, which is across the country, US data. They did an adjusted analysis of a little over 1,200 pregnant women, and essentially they were sort of comparing, severe versus severe COVID infection versus mild disease. And here you can see cesarean delivery was much more common in those with severe critical COVID infection. And I think the reason is what I was explaining. You have someone in the ICU, they're incredibly sick, and the likelihood that they are going to be able to, withstand a vaginal delivery and push, et cetera, many times cesarean delivery is the choice. Hypertensive disorders also much more common in those with critical illness. Next slide, please. And then just so that I don't sound like totally a maternal person, although I really am a maternal person, the birth and infant outcomes after COVID infection and pregnancy, I think all of us were very much sort of waiting to see what's going to happen with these babies, wondering what the maternal fetal transmission of COVID would be for the women who were getting sick, especially those who were sick enough to land in the ICU. This is just one paper that came from CDC data of over 3,000 infants who were born to women with documented SARS-CoV-2 infection. The preterm birth rate's a little bit on the high side, 12.9%. And then among those infants who tested positive, of those who had test results, only about 2.5 were positive for SARS-CoV-2, which is interesting, suggesting that the in utero transmission rate actually is quite low. And then other numbers thrown around. The highest I've seen actually has been about 4%. So I think that this is not sort of the major issue here. It's really about keeping the mom healthy so that she doesn't have a severe infection or then have a preterm birth. Next slide, please. So I throw this slide up there because this is really current state, and I think people can recognize that initially we didn't really have much data on pregnant or non-pregnant individuals, and as that data started to amass, we started to get this picture where clearly pregnancy was a risk factor for severe disease, much like we see with influenza. But at the beginning, we didn't really know if it was going to be like influenza. But clearly it is. And I think that what this shows is that there's no question that as you can see here, infection happens in any trimester of pregnancy, first, second, or third trimester of pregnancy. This happens to be, I should have said, I'm sorry, this is from the CDC COVID tracker, where you can get incredibly well done, up-to-date data. This looks at over 28,000 pregnant women who have been infected with COVID-19. And 97% of them, they actually had the data on which trimester they were infected. Also, this one that I happen to click on gives you race ethnicity, which I think just highlights the racial and ethnic disparities that we've seen in COVID infection in non-pregnant individuals. Absolutely 100% mirrors what we see in pregnant individuals. So this is the state. Women are sick. they get really sick, and that can happen at any point in pregnancy. So let me have the next slide. So this slide, I love this slide, and the reason I love this slide is because it reminds me of where we were and the fact that back in July 11th, 2020 in the New York Times, which is where I plucked this from, the bottom line is that, oh, we're not going to see a vaccine for, at least a year, and, keep your fingers crossed. And then as I see it, this is sort of the greatest benefit of science, right? And the miracles associated. So if we could just get people to utilize the vaccine. So next slide. I think in having the conversation, certainly when talking to pregnant women and actually just young women in general, I think in having the conversation about vaccination and should you or shouldn't you, how much data is there, really my experience has been, and I think all of the data would show, that pregnant women are most worried about safety. They're not as worried about their own safety as they are about the safety of their children. And I think that it is important to share with them that the US has a very robust safety system, and that system was rolled out immediately, is ongoing and was immediately sort of upgraded, if you will, to react to these new vaccines that came on the market. And as a reference, many of you will remember when the original clinical trials on the Pfizer and Moderna vaccines came out, there was no, pregnant women were specifically excluded from those clinical trials. So initially, we were making recommendations based pretty much on animal reproductive data, number one. And number two, sort of the biologic plausibility that these vaccines would be safe. And number three, probably that I should have, sort of said that it was number one, was the evolving information of how severe COVID infection could be in pregnancy. So putting those things together, we were making a recommendation that pregnant women certainly not be excluded from being vaccinated. It took us a little while to then get to the recommendation that they definitely should be vaccinated. The other thing that I throw in my VSafe here, the VSafe was an added sort of safety mechanism, which really belongs under VAERS. And that allowed pregnant women to then identify pregnancy, which was awesome, identify pregnancy and identify that in relationship to when they got the vaccine, and then give the information about what their symptoms, et cetera, were. And that turned out to be the first safety data that came out in pregnancy based on the vaccine. So next slide. So there's a little bit more about VSafe, and I think this audience probably is sick of the information, but I have to tell you, having been in the vaccine space for a really long time, where pregnant women are left out because we don't have the information, VSafe was absolutely critical, because one of the questions is, are you pregnant? And if so, when, and how many weeks? So that's really super important. And then, so it captured pregnancy status, and it enabled the CDC then to specifically reach out to pregnant women and get more information, which is basically what happened. Next slide, please. So at this point, this is updated periodically, and so this one, when I captured the slide as of October 4th, there are over 163,000 plus pregnant women who have been vaccinated, and then there are 5,000, a little over 5,000 of those women who have actually been enrolled in a specific pregnancy safety study, where they're called and more questions are asked, and information about the course of their pregnancy, pregnancy complications, and issues with their baby are all planned. Next slide. And as I said, this is where we got the first bit of information, safety information. So these are preliminary findings from the VSafe data. And this was shared in the New England Journal by the VAERS group from CDC. And what you see here is in the first figure was information that I think was helpful to patients, was to recognize that pregnant women were no more likely to have severe reactions, if you will, to the vaccine than non-pregnant individuals. One thing that had come up and created lots of consternation was, oh my gosh, will pregnant women have more fever? Is fever going to cause a problem for their baby, et cetera, or cause a problem for them? And as you can see, a fever happens, but it's actually a small number of women, and the response to it is take Tylenol, that fever will go down, and the fever doesn't last that long. It was very helpful to have this data because I think that that was a concern, an early concern of pregnant women, and we didn't have the clinical trials to really know what was going to be the effect of these vaccines. So this was great to see. Next slide. And then came other safety data. This is the same. Was in the same study, again from the VSafe data, and there was data on about a little over 800 participants who, most of whom were vaccinated. It was actually more than 800, but 800 had been vaccinated in the third trimester and finished pregnancy, for which we had data. As you can see here, we were able to see that the preterm birth rate wasn't any higher than you would expect for those who were exposed to the vaccine. Small for gestational age, congenital anomalies were few, and neonatal deaths, thankfully, were non-existent. And obviously, everyone recognizes that this is a small data set, but certainly in the midst of a pandemic with women getting seriously ill, it was incredibly good to see that the vaccine was safe and that we had some good data to put out to the public. Next slide. In that same paper with the preliminary data, unfortunately, there weren't enough pregnancies where patients had received, where pregnant persons had received vaccine in the first trimester. So a lingering and always concerning question that comes up from pregnant women, pregnant people, is the risk of miscarriage. And although from a biologic plausibility standpoint, we did not feel that there should be an increased risk in miscarriage. This is always a concern, which is very helpful to see two different studies come out recently. The first was a research letter that was based on the vaccine safety data link data. This was from Carbonda et al. And what they were able to show is that the odds of having a miscarriage within 28 days of receiving a vaccine, mRNA vaccine, was not elevated, and so you were no more likely to have a miscarriage, and that held true for both Moderna as well as Pfizer. That was incredibly important to see. The second research letter that came out from the New England Journal actually is based on VSafe data, so that same data that I mentioned to you before. But in that initial preliminary data, there wasn't enough information on spontaneous miscarriage to really be able to say anything. So they went back and looked at a much bigger data set from this same VSafe, and they were able to include over 2,400 pregnancies where they had at least women who were exposed to the vaccine and had gotten to at least 20 weeks gestation. And from that data, you could tell that the cumulative risk of having a miscarriage, if exposed to the vaccine, was about 14%, which is really, if you look here, it's very consistent with other studies of the natural likelihood of having a miscarriage for all the millions of reasons that these unfortunate events occur. But I think what is incredibly important to patients is that we can say to them the risk of having a miscarriage is not higher when you get one of the vaccinations. And thinking back to the epidemiology, I think it's super important for patients to understand that you can get sick in the first trimester of pregnancy with severe COVID. So you need to protect yourself even, and so that may be getting the vaccine in the first trimester or in the periconception period. Next slide, please. So I think obviously, as I mentioned, safety data is super important. Glad we have it. It does help us make the case for the need for the vaccine and the safety of the vaccine. I like to throw in a little other added benefit. This is a paper from one of my colleagues here at Cornell, looking at maternal COVID vaccine antibodies induced by the obviously by the vaccine, and crosses through the placenta and can be measured in cord blood. And what you can see essentially, and what we found here, is that women who are fully vaccinated prior to delivery do have a robust immune response and can measure those neutralizing antibodies in maternal blood, and then see those see fairly robust antibodies in the cord blood, and potentially those are the antibodies that will protect the baby from infection as a newborn. Obviously, as Dr. Ray mentioned when she was talking about why we shouldn't be checking antibody levels, there is no clear correlate of protection. And so I can't necessarily tell a patient, oh, yes, you have enough antibody to protect yourself and your baby. I wish I could. But we can presume at least that those antibodies do cross robustly. And we're going to have a paper coming out fairly soon suggesting that even getting vaccinated in the first trimester, there are antibodies that will cross the placenta. I think that something that comes up not infrequently from patients all the time is, and they will say literally, when is the best time for me to get vaccinated during pregnancy? And I think that one thing that we have to be very consistent with is that we're vaccinating mom to protect her health. So when they say, oh, I want to wait until the third trimester to give the baby more antibodies, I always like to say, but we don't want you to wait 10 or 12 weeks with the potential to get sick in the 10 or 12 weeks as you're trying to improve things for your baby. So I think we need to keep that message going. Next slide, please. Next slide, please. So this again comes from the COVID tracker, and I just throw this up here. I didn't know that Dr. Ray was going to give an update on sort of the epidemiology. This is the epidemiology as it looks in pregnancy, and I think you will recognize that the peaks are exactly what we see in the non-pregnant individuals. I think the other thing that is incredibly sad and important to recognize is that there have been reported so far 171 deaths in pregnant women with severe COVID-19 and infection. And I think not only obviously is that a horrible tragedy of something that is preventable, but we also need to remember the downstream effects of losing a mother and the effects on those children who are born in the families that are disrupted. Next. So that brings me to almost my last slide, which is this one that just gives me angina. I am incredibly sad because I've been talking about vaccines in pregnancy forever, and we just haven't gotten the message across. I think this is data showing how low the vaccination rates are in pregnant women. It's somewhere around the 30% range, which is what was in the last TON. And so our jobs, we need to really double down. Pregnant women need to understand sort of the risks that they're taking in not being vaccinated. I have, I think, one last slide and then a summary. Okay, so I think this is another area that, although I am very pregnancy focused, you can tell, I recognize that, we cannot forget that there's vaccine hesitancy also about the concern of infertility. And so I wanted to put this up so that people just know that there is some data, not a lot, but there is data to suggest that, these COVID vaccines do not interfere with fertility. I think it's clear that the biologic plausibility was weak at best, but it grew from misinformation from a researcher early on who suggested that there was a similarity between syncytin 1 and SARS-CoV-2 spike protein, and that if you were vaccinated, you might actually induce immunity to your own to yourself and then cause female sterility. And so that misinformation unfortunately sort of took off like wildfire. I think these are two studies, are not huge and robust, but I like to have some science behind it. I think this first study on the left by Orvieto, what they attempted to do was to show that patients who were vaccinated versus those who were not did not have any difference in their response to IVF, which I think is obviously incredibly important. The second study was looking at this whole spike protein seropositivity that you get from the vaccine and or the infection, and interestingly, there was no evidence of sterility. And they were looking at sort of frozen embryo transfers and looked at women who were SARS-CoV-2 vaccine positive, those who were infection positive or natural infection positive, and then those who were seronegative women, and they could find no difference in serum HCG implantation rates, or which is important, obviously, if the pregnancy doesn't even get started, obviously that's a problem. But in addition to that, sustained implantation rates between the three groups. So I think that is very reassuring and should be repeated to patients when they bring this to our attention. I'll just finish on one other thing, which, you live and learn. I've done lots of public speaking, and every now and then, as we all do, you sort of misspeak and wish you hadn't said it. So on NPR, apparently I gave the impression that I didn't take the menstrual cycle issues that have been talked about with the vaccine seriously. And it's not that I don't take it seriously, it's more that I thought it was important that, for what little we know, it seems that the complaints that patients call with in general with menstrual irregularities are really quite transient. The Brits have taken a bigger look at this, and again, they find that it's one cycle and then the next cycles are all fine. I do think that what we've learned, though, is that these are things that are important to women, and going forward, we need to be able to get the data in a rigorous way so that we can have answers to these scientific questions that are important to patients. So my last slide, next to last, sorry, another one. Thank you. So just in summary, I think I've convinced you, and I think that these are the sort of bullet points that I like to share with patients, recognizing that COVID infection in pregnancy is associated with severe morbidity as well as mortality, and that these cases happen in even, completely healthy, pregnant women. We need to recognize and take seriously the physiologic changes of pregnancy, which probably set women up for doing poor, or people up for doing poorly. Current data suggests that, it's mostly hospitalized pregnant women are unvaccinated, and that only about 30% of pregnant women are vaccinated at this point. The vaccines are safe during all trimesters of pregnancy, including preconception, and we should be encouraging that. No evidence that it's associated with infertility. And then also to the young women who are really worried about the menstrual irregularities, I think it's important to let them know that recently the NIH put out 2 RFPs to actually significantly, to robustly study it. And then the last thing I'll say is that I just was reading a paper that came out. Well, actually, I think it's not out in print just yet, but in the obstetrical literature, which came from Oxner in Louisiana. And, they have very good data suggesting that unvaccinated women are really the ones who are doing poorly in the hospital. Yet another reason why we need to really work harder. So with that, I will finish, and hopefully, I haven't left much time for questions, but I'm happy to answer whatever I can. I have trouble reading the chat and talk at the same time.
Thanks so much, Dr. Riley. That was a great presentation. Actually, most of the questions you answered in the following 1 or 2 slides, so you anticipated them.
Oh, good.
But,
That's great.
I think, we have sort of, I'm extrapolating from several of the questions, but can you speak to, we had a question specifically about preterm birth with COVID. Can you speculate about the sort of like an order of magnitude or a number that the providers can offer in terms of protection? So the vaccine will protect you this much or this many times.
Oh, I think that's kind of hard. I mean, I think that it depends on what you read, but, the preterm birth rates of 13, 18% are double what you'd expect in the general population. But again, it depends on where your population is. I think what I try and stress more is the fact that we need to protect mom, because if mom gets severely ill and lands in the ICU and has, hypoxia and ultimately dies, obviously there's no baby, right? Sometimes there is a baby, but now there's a baby with no mother. And so I think that's really sort of where we need to put our focus, is that we need to protect mom from maternal disease, because, and we know that those preterm births are in general women who are really sick. Right, so they have this, massive inflammatory response, and inflammation is the worst thing for pregnancy. Causes contractions and, causes the whole cascade that leads to eventually early delivery sometimes, or it leads to iatrogenic prematurity, right? So if we're having trouble ventilating a mom because she has severe COVID, one of the things in our, toolbox is going to be to empty the uterus and make space for those lungs. So, we've got the preterm birth piece in 2 different places.
Thank you, Dr. Riley. I'm going to actually have Dr. Rosen answer one question quickly, and then hopefully we'll have a minute for you to speak generally about just your strategies for convincing pregnant people to get the vaccine. But prior to that, Dr. Rosen, can you talk about boosters after breakthrough infections? The question was specifically about any potential additional immunity after a breakthrough infection, and whether that maybe boosts the immune system to an extent that even if indicated, a person would not need a booster shot.
Sure. So the recommendation for a booster dose, or for the primary series for that matter, does not take into account prior infection, whether it was a breakthrough infection after vaccination or otherwise. So people who haven't been fully vaccinated with the primary series should get vaccinated regardless of whether or not they've had past infection, and people who are recommended to get a booster dose should do so regardless of whether they've had any form of past infection.
Thanks so much, Dr. Rosen. And then Dr. Riley, maybe we can just hear about your experience and your strategy convincing pregnant people to choose to get fully vaccinated.
Yeah, I mean, I usually talk with each patient about the need to protect themselves. I also talk to them a little bit about the baby, but I really try and focus on mom because I think that it's that focusing on the baby that gets us into the, well, but is there long-term safety data? And you got to tell the truth. We don't have long-term safety data. The vaccines haven't been on the market that long. And sometimes that then derails the conversation because I, tell them that, oh, I don't have that data. I do share all of the data, all the safety data that we do have. And I see that there's a question in the chat about, can you speak about the risk of fetal development in the first trimester after receiving the mRNA vaccines. And I think I think what that question is, are we seeing an increase in congenital birth defects? And we haven't seen that. But I also recognize, as do you, that you need lots and lots and lots of babies to be born in order to see if a particular drug or vaccine is associated with an increased risk of congenital abnormalities, especially if it's something that's super duper rare, which clearly this is, because we've now had lots of babies born. There's been no pattern of malformation seen or anything like that. So I feel like we're getting to the point where we can, really say that to patients and say we have a robust amount of data to be able to make that comment. But a lot of my patients are very savvy and they will say, but what about the brain development when the kid is 6 years old? Well, obviously I don't have that data. Your kids aren't, vaccine hasn't been around long enough. I think in that instance, I also do talk to them about the fact that there's no biologic plausibility that we think that this is going to affect anything in terms of development. And again, I think that there's lots of evidence that pregnant women do very poorly when they get COVID. I think it's also important, COVID infection, and I think it's also important for them to understand that we're not great at predicting who's going to be the person who lands in the ICU. Yes, if you have asthma, obesity, whatever, these comorbidities, that increases your risk. But even young, healthy, pregnant women are landing in the ICU with all sorts of, sort of ECMO and other really morbid procedures happening.
Thanks so much, Dr. Riley. I think maybe since we started late, we can do one more very, very quick question, which I have been encountering a lot. There's a lot of fear around breastfeeding or getting the vaccine while breastfeeding. Are there any benefits? I mean, I know you said that it's not harmful, but in your opinion, are there benefits, even if we don't have solid data about it?
Oh, I think there's definitely going to be benefits. I think it's a matter of time before we see really a lot more data on the antibodies that are passed through breast milk. We know that, in general, breastfeeding moms can help prevent other infections like ear infections and things like that. And so I think, it's just going to take us a little while to get that breastfeeding data. We're collecting it, I can tell you. So if you know anybody who wants to join a study, we have a cover trial here at Cornell. So we're looking at breast milk and trying to see how much antibody response actually gets transferred to the baby. But I think it's only going to be beneficial, just as we saw with antibodies that are transferred through the cord.
Thank you so much. I think with that, Allison, can you talk about when the next webinar will be scheduled?
Thank you, Dr. Ray. We do not have our next webinar scheduled, but we have been offering them on a monthly basis for now. So, if and when the next one is scheduled, we will let all attendees know via email and also update our provider facing webpage with that information. You can see the link for that under General COVID-19 resources on your screen currently. And that page is also where we will be uploading a copy of these slides as well as a recording of this webinar by tomorrow. So I think we are done. Thanks to those who stayed with us a few minutes over time today, and thank you again for joining us.
Thank you.
Thanks all.